I'm happy to share the stage with esteemed doctor. Especially, I'm blessed to have Dr. B. Srinivas sir here as my teacher. I can proudly say I learned so many points from Dr. Srinivas sir. So, coming to my topic, first I start with the definition of the MINOCA. MINOCA and INOCA, as everyone know, MINOCA means myocardial infarction in non-obstructive coronary arteries, and INOCA means ischemia in non-obstructive coronary arteries. So, first to know about the MINOCA, we should know the definition of the MINOCA. To say MINOCA, it should fulfill the three criteria. One is it should satisfy the criteria of acute myocardial infarction according to the modified fourth universal definition of myocardial infarction criteria. Should the detection of the rise or fall in troponin values with at least one value above the 99th percentile upper reference limit, along with the corroborative clinical evidence of infarction evidenced by at least one of the following: symptoms of myocardial ischemia, no ischemic ECG changes, development of pathological QX, imaging evidence of new loss of viable myocardia, or new regional wall motion abnormality. So, if acute myocardial infarction criteria everybody knows, if satisfied this, then you go to the next criteria, that is do angiogram. If angiogram shows obstructive coronary arteries, 100% occlusion artery, which explain the infarction, it's okay, it goes to the other direction. But if you see angiogram, surprisingly you see normal coronaries or non-significant coronary artery disease, then it comes into the MINOCA. Of course, it should, if it matches the two, still we need to have it need to fulfill the third criteria, that is there should not be any alternative diagnostic for this clinical presentation. So, if you see a clinical presentation of the patient like this with satisfying acute myocardial infarction along with the normal coronary arteries or non-significant stenosis like less than 50%, so you make a diagnosis of MINOCA. Then at this juncture I would like to ask two questions. If you see this type of patient, so where do you think pathology lies? You think there is a MI one side and normal coronaries are insignificant coronary artery disease. Where do pathology lies? So pathology most of the times lies in the coronaries itself, but we need to investigate thoroughly. Further investigations are needed. Our second question is, if you see this type of picture, what do you do then? You want to discharge the patient by saying the ECG changes are false positive, or you want to say the patient that we want to further investigate to make a diagnosis of something is there, and we will give a proper planning for his future events. So if you discharge him like that, it's like a crime, because you see, when you go to if you see the data from so many meta-analysis, so it shows that MINOCA patient, when compared to the normal CVD patients, the mortality rate and non-fatal MAs are very high, but of course definitely when compared to the obstructive coronary arteries is less, but definitely compared with the normal coronary arteries significantly high. If you see sweetheart registry and cath PCI registry and multiple meta-analysis studies, see there is a significant death rate, recurrent MIs and heart failures varying from 6.4 to 13.4% if we follow them for 4 years. So if you see this data, definitely you will not discharge that patient, you further evaluate. Next slides, I will tell you why we are missing this, the pathology in this type of MI cases. So, to know that, we should have a fundamental idea about the pathogenesis of this infraction. So, as everybody knows, there is a necrotic plaque. In the plaque, there is necrotic area, inflammatory cells. If the inner pressure of this plaque core, necrotic core is increased, then obviously there is a rupture of intima at this point that exposed to valve-brand factor to the flowing blood, so that attracts the platelets and formation of the clot occurs. If the clot is sufficiently significant enough, then that can be visualized in angiogram. But if you imagine if this clot, if it is thrombolized spontaneously without doing anything, by the time of angiogram you can see non-significant stenosis and you misdiagnose as it's a culprit for that MI. And if the lesion is like a small thrombus, then also you can miss. By angiogram mostly appears like a normal or minimal luminal stenosis. So conceptually matching, see if you see these three types of presentations, so there may be vasospasm, there may be lesion first, plaque with the plaque rupture and formation of small thrombus initially, or added to that there may be vasospasm. Combinedly they can present with the MI. Sufficient time, if it happens, vasospasm and thrombus, there may be formation of MI. But when the time of angiogram, the vasospasm is relieved and you can see this thing only. Same thing if lot of thrombus formation without vasospasm, but at the time of angiogram, by the time you take to the angiogram, there may be lysis, spontaneous lysis, and we can see insignificant disease in the coronaries. And similarly, when only isolated vasospasm is happening, it lasts for significant time causing infraction. But when you take to the cath lab and do angiogram, may appears like a normal coronaries. And here one more diagnosis, like it is a spontaneous coronary artery dissection, in which the pathology lies between the two layers. There is separation of media from the adventitia and creating a potential space between them. It causes the luminal obstruction, and so there is no flow in the coronaries. So lumen is completely occluded here. So the patient develops MI. By the time you take into the cath lab, there in the intima there may be tear formation, leads to decompression of this space between the two layers, and the flow establishment occur. This leads to to show the image as a normal. Other proposed mechanism is there is a lesion here in the main branch, but the pathology lies here, thrombus formation occurring at the side branch, and this thrombus formed and dislodged into the distal small vessel. Small vessel may completely occlude at the starting point. You may not see that in the angiogram. You think that this is almost like a normal angiogram, and you can discharge the patient. You may discharge the patient by saying it's normal. And here, why we interpret angiograms as the normal most of the times is, see, angiogram is a two-dimensional modality. We see imaging most of the times imaging is okay, but sometimes if you are not seeing in a multi directions, see this image in this angiogram appears like a same lumen diameter here and here. But I was in the first place is showing the luminal diameter is good, but here there is a crescentic plaque which is compromising luminal diameter, and you may miss if you don't do imaging.